Okay, students, this is chapter 28, Care of the Mother and Newborn. So we just finished the labor and delivery chapters, chapters 10 and 11 in your ATI book, and chapter 27 in your big book. Now we're moving into chapter 28 in your big book, and we're going to be covering several of the chapters inside of your ATI book, starting with chapter 12. So we're going to integrate concepts from chapter 12 and chapter 13, some chapter 14, um, 15, 16, and then a little bit of 17. I will say that the complication chapters, so 17 and 14, are going to be covered in the next set of slides, just a little bit more in depth. But we'll go ahead and get started. Okay, so overview of are an anatomic and physiologic changes. Apologize for my word slip up there. So what is happening to the reproductive organs, the cervix, the vagina, the perineum, the breast, and other body systems postpartum? So we see a lot of different changes, right? So the first change that we see is that involution of the uterus, right? So that is the uterus moving back down into its normal spot. So involution occurs when we have those contractions of our uterus with its smooth muscle, and it allows us to go back to our pre-pregnancy state. This is a rapid decrease. So, you see it be humongous, right? A thousand grams, a kilo, right? 2.2 pounds when we're done having this baby, all the way down to only 60 to 80 grams at 6 weeks postpartum. And we're moving down about a finger breadth each day. So one finger breadth is 1 centimeter. Right after our moms give birth, the fundus, that top part of their uterus, is going to be firm and midline, and it may be 1 to 2 centimeters below their umbilicus or their belly button. 1 hour after delivery, we do see it rise just a little bit, up to 12 hours after delivery. And at that point, it'll be about 1 finger breadth or 1 centimeter above the belly button. This is the only time it's okay for it to go up. After that point, it should always be going down. If the fundus is rising after the 12-hour point, we're concerned for uncontrolled bleeding, postpartum hemorrhage, retained clots, potentially retained placenta. And so we really would be concerned. Every 24 hours after that 12-hour point, we should be moving down 1 to 2 centimeters. And then eventually, by about the sixth postpartum day, we should be halfway between that symphysis pubis and the umbilicus. So somewhere between U-4 and U-5. Okay, so you need to make sure that you're palpating this uterus, right? That's super important. It needs to be done at least every 8 hours after those postpartum recovery vitals. And make sure you're explaining what you're doing to the client because it's not comfortable. It can be very, very painful. So you want to position the client flat with their knees slightly flexed so that way their fundal height is not off. If you have them sitting up, you can actually falsely like boost up their fundus. And so you definitely want them to be laying as flat as possible. And then you're going to put on gloves, right? And you're going to make sure that there's a pad under her bum because when you press on the top of her fundus, you're going to see lochia flow from the vagina. So you want to make sure she's got some coverage there for that leakage. So you'll put one hand just above the symphysis pubis to support that lower segment of the uterus, right? And if we don't provide that support, we could potentially invert the uterus, which would be very bad, right? We don't want to do that. So we're going to apply that support, and then we're going to use our other hand to palpate the top of the fundus, right? We never want to palpate without cupping the bottom because, again, we could cause a potential inversion. We're really looking to see how high is that fundus as compared with that belly button. How many finger breadths fit below that, the top of the fundus and the umbilicus? Is it above the umbilicus? Is it below the umbilicus or is it at the umbilicus? If it's above the umbilicus, we're documenting that as +1 or U+1, which means 1 centimeter or finger breadth above. And if it's below, we're documenting that as -1 or U-1, which means 1 finger breadth below the umbilicus. Additionally, we're palpating to make sure it's midline. Remember, if it's displaced laterally, that means to the left or to the right, that typically means your mom has a full bladder. Having a full bladder is a problem because the uterus is not able to appropriately contract and therefore stop bleeding and involute, right, or involve. So that would be an issue. Additionally, and probably the most important thing for you to remember is that the fundus should always be firm, nice and hard. It should feel like you're palpating a cantaloupe inside of that uterus. or excuse me, inside of the abdomen. That fundus should be firm. If it's not firm, if it's squishy, mushy, or it's hard to even feel it, that's called boggy, Boggy, a boggy uterus. That is not good. What we want to do is immediately massage that fundus in a nice circular motion, giving it a little rub. What that rub is going to do is actually cause those muscles to contract and helpfully stop the bleeding and cause that uterus to firm up. Remember, uterine massage is not a comfort measure. It's actually incredibly painful, but massaging the fundus is the first thing you should do if you palpate a boggy fundus. We should always watch and see if there's excessive bleeding when we palpate the fundus. And if there is excessive bleeding from the vagina, we may need to give a medication like oxytocin or misoprostol, right? We can also give a medication like a methergin or methylorgonavin, or carboprost, right? Hemabate. Those medications will help the uterus to clamp down more effectively postpartum. And then we want to encourage early breastfeeding. We know that that will stimulate oxytocin and allow uh, mom's uterus to clamp down a little bit better and keep us from hemorrhaging. And then, of course, encouraging emptying of the bladder to prevent displacement and that uterus not being able to be nice and toned. As far as the cervix, the vagina, and the peri area, we might see a lot of swelling. Um, Things that we might see, the cervix will be soft, but it may be bruised or swollen. We do see that it does shorten after a couple days postpartum, and then eventually that os or that opening does close of the cervix. If you have lots of ouchies to that cervix, so lots of lacerations, you may see a decreased amount of cervical mucus, and then it won't be as pretty, right? There's not going to be a round dimple shape to it. It'll have a slit-like shape to it. So that cervix has just been through a lot, right? Stretching to 10 centimeters and then coming back down. The vagina may be distended, right? And eventually that'll go back to the normal pre-pregnancy state. The rugae will come back, even though that they've disappeared now. So that basically wrinkled or ridged appearance of the vagina. Um, Although, most things go back to normal, unfortunately, after having a baby, that muscle tone is never totally the same. So there will be some changes in the tone of the vagina after having a baby. Things like estrogen creams later on in life may help with that. But for now, we're just hoping that everything goes back to normal as much as possible. And if you breastfeed, we actually see that causes worsening of vaginal dryness and atrophy. So that's just kind of interesting. As far as the peri area, there's going to be a lot of redness, a lot of swelling, especially if there was an episiotomy or a laceration. There may be a hematoma, which is like a bruise that's formed, or even hemorrhoids, right, from the pressure of pushing. We might see some of those veins of the anus popping through. And then those pelvic floor muscles may be overstretched and weak, which may result in a little bit of, urinary frequency or perhaps incontinence. We're going to be checking that peri area as the nurse. We're documenting what we're seeing. Is it red? So is it erythematous? Is it swollen? Is it edematous? Is there a hematoma or is it healing well? We're going to look at that episiotomy site and those lacerations. We're going to see how well approximated they are, how much drainage we're seeing from that site, how many lacerations they are, how deep they are, how long they are. A bright red trickle of blood from an episiotomy site is totally normal initially after a postpartum in the postpartum period. That is totally normal. Initial healing, we start to see some good healing within 2 to 3 weeks, but it's going to take up to 6 months for that to be totally healed. Now, if mom is really tender, she's got a laceration or episiotomy, we might want to put her on stool softeners to help her produce stools without a lot of pain. We also can apply ice packs or cold packs to the bottom for the first 24 hours. We don't want to apply those directly to the perineum, but we can put them inside like a washcloth or inside of her panties. You can use heat therapies. They don't recommend those for the first 24 hours, but afterwards you could do, hot packs, moist heat, sitz baths to help increase circulation and help her heal and be more comfortable. Sitz baths can be either hot or cold, and that's where they're just soaking their bottom, right? 20 minutes at least twice a day is recommended for those sitz baths. Now, there are medications we can give to help with the pain in the peri area. We can give acetaminophen, which is Tylenol. We can give NSAIDs like ibuprofen, and we can also give opioids like codeine or hydrocodone, so like Percocet or Vicodin, right, for pain and discomfort. And then if it's a really bad delivery or we have a C-section, they may be put on a PCA pump, so a continuous infusion of pain medication. There's also topical sprays that they can do. It's like Dermaplast spray, right? It's typically like a local numbing cream or spray that we can use. And they can also use witch hazel compresses. Those really help with the discomfort of the peri area, but also for hemorrhoids. So making sure that they're washing, they're using their little peri bottle to spritz and clean, and then things like distraction imagery and progressive relaxation may help them control some of that pain and tenderness as well. Clients should obviously wash their hands, use that squeezy bottle like we talked about after they use the bathroom. And then they should never wipe from front to back, but they should blot. So tap, 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 tap. That's going to help it be a little bit less painful. Okay. As far as sexual activity, we really shouldn't regain any type of sexual activity for quite some time. They can safely resume sex by the second to fourth week after birth when bleeding has stopped, but most people recommend 6 weeks because that's when they're going in for that check with the doctor to make sure everything is healed well. And then obviously the body might not respond the same to sex, and the physiological reaction, like the elongating of the vagina and the lubrication, natural lubrication that's produced, may not be as quick and effective, especially initially. And orgasm may be difficult to reach for the first 3 months after birth. So just something to think about. Regarding contraception, it is very important that there's contraception involved if you're resuming sexual activity. But if you're breastfeeding, you should not take oral contraceptives until you've got a good supply of milk, and that's usually about 6 weeks. Um, Clients that are not lactating or not breastfeeding, they may not get their period for 4 to 10 weeks, but they can ovulate even without the period. So up to a month after delivery, they could be ovulating already. And then lactating clients and those that are breastfeeding typically do not have a period at least for 6 months or until they stop breastfeeding. As far as what we see coming from the vagina, it's that lochia, right? That post-birth uterine discharge. It contains like blood and mucus and tissue, et cetera. And it just depends how much you have. Really depends on your body and how it's responded and what kind of trauma you've been through with this delivery. If it was easy peasy or not quite so much. But we do see 3 different stages of lochia. The lochia starts as lochia rubra. That's a dark red color, looks a lot like blood, like menstrual period. It does have debris from the inside of the uterus. It's got a fleshy odor. It can have little clots in it, and it'll have a transient flow. So when you breastfeed, you might feel a gush because the uterus is contracting down with that oxytocin. When you stand up, it may have pooled inside. And so there's a little bit of a gush when you get up. About 1 to 3 days after birth, you should be seeing this lochia rubra. It's important to teach the client that when they stand up and they see an increase in discharge of this lochia, that's not necessarily a hemorrhage. That could just be from them being recumbent for a period of time and that pooling inside of the uterus and then eventually finding its way out with the change in position. After about day 4, we see that lochia turn into lochia serosa. It's pinkish brown, serosanguinous. It can still have some small clots, and then that'll last till about day 10. And then after day 10, up to 6 weeks postpartum, you may see lochia alba, just a yellowish, white, creamy, fleshy smelling discharge. Lots of mucus in that as the peri area and the vagina are healing. We really have to assess lochia. So we are assessing the fundus. We talked about that, but we also have to assess lochia. So we're assessing the color, but we're also assessing the amount of that lochia, and that's how much of their pad they saturated. If it's less than 2.5 centimeters of their pad, we call that scant. If it's between 2.5 centimeters and 10 centimeters of their pad, we call that light. If it's more than 10 centimeters, that's considered moderate. And if they saturate a pad within 2 hours, that's heavy. So that's how we determine the amount: scant, light, moderate, heavy, based on how much of the pad is saturated. Now, if one pad is saturated in 15 minutes or less, or we've got blood underneath the bottom, that is a postpartum hemorrhage. Immediately, we should be telling the charge nurse and the provider, palpating the uterus, starting uterine massage, giving oxytocics, doing things to support mom. So we're checking the color, we're checking the amount. We're also looking for odor. If there was any odor, we'd be concerned about potential for infection. And then also the consistency. Is it thick? Is it chunky? Or is it very thin? You need to monitor that lochia frequency every 15 minutes for the first hour and then every hour for the next 4. So using those recovery vitals kind of as a format for that. It should trickle. Um, and then when you have uterine contractions or you breastfeed, it'll definitely be a little bit more of a steady flow, but it shouldn't be pooling, right? If it's pooling, we've got some heavy bleeding, and that's really concerning. When we massage the uterus, when we do the spondyle assessments, or when we get up and move, we can see a gush of that, or we can see clots come out. And that's okay. Again, clots are okay too, as long as they're not larger than about the size of a golf ball or an egg. That would be concerning. What else do I want to tell you? I mean, obviously, there's excessive spurting of bright red blood. That would be really concerning. We would think maybe there's a tear of the vagina or a laceration to the cervix. If there's lots of large clots, if we're saturating that pad, in 15 minutes or less, we're worried about hemorrhage. And then persistent heavy lochia after day 3 in that lochia rubra color would be concerning for potential retention of a placenta, right? So we would be worried. Make sure your client's changing their pads frequently, washing their hands, and not using tampons during this period of time. Okay, I know it's a lot of information, but we want to talk about all the physiologic changes that we see. So let's talk about the breasts now. There are going to be physical changes in the breast, including a secretion of colostrum, that liquid gold. It is a yellow color, and it happens during pregnancy and then 2 to 3 days immediately after birth. Milk won't come in until 72 to 96 hours after having a baby. So what they're going to be drinking in the meantime is that colostrum. But that's good because it is rich in antibodies and things that will help protect baby from infection. So, as the nurse, your job is to inspect the client's breast, figure out what the client's choice is, if they're going to breastfeed or formula feed, really provide that education about when their milk is going to come in. And then you're going to be monitoring for engorgement. So hopefully mom's already home before that 72-hour mark and their milk comes in, but you should be teaching them about it regardless. And that's a fullness of the breast tissue that's caused because we start to develop that milk, right? There's some venous congestion there. The breast may get really tight, tender, warm, and full. If they don't plan to breastfeed, it will go away. They can use a binder on their breast, wear a supportive bra, ice pack, or cabbage leaves to help dry it up. But they should not be stimulating their breasts. They should not be, trying to relieve the engorgement by pumping their breast or expressing milk from their breast. They should not be running their hot water over their breasts. All of that's actually going to continue to stimulate the breast to make milk. And so if they're not planning to breastfeed, we want binders and ice and cabbage leaves on those breasts. If they do want to breastfeed, we want to do frequent feedings. We want to take care of those breasts. Warm compresses are great. We may use a little lanolin to help with the nipple soreness, right? You're going to be looking at the breasts for any redness, breast tenderness, cracked nipples, or any indication of mastitis, right? That's where we have an infection in a milk duct. They'll have like flu-like symptoms. There'll be redness. It'll be hot to the touch. Unilateral, usually. And then you're going to want to help mom latch the baby. So you want to make sure that that baby is latched correctly and that we have reviewed different positionings like the football hold, the cradle hold, a side lying position for breastfeeding, and making sure that we find something that's really comfortable for mom. It is important to start breastfeeding within the first hour or so after birth and then to feed on demand. So when that baby wants to eat, we need to be feeding that baby. And remember, breastfeeding is going to help with preventing hemorrhage because that natural oxytocin is going to be released that helps that uterus to clamp down. What else can I tell you? Think that's pretty much it for breasts. Let's talk about some other systems and like the changes they go through. Again, this is all from chapter 12 of your ATI book and chapter 28 from your big book. So, in our cardiovascular system, the postpartum period, we see some changes. We see obviously blood loss up to 500 milliliters for vaginal, up to 1,000 for cesarean. Anything beyond that would be a postpartum hemorrhage. Because of that blood loss and that loss of a ton of fluid, we may see sweating and lots of peeing from mom. Mom may have some weight loss, right? That should be expected, about 19 pounds or so, 8.6 kilograms. Uh, Mom does not typically have any issues with losing all this fluid, but we could potentially see hypovolemic shock in extreme cases. Um, especially like when the placenta pulls off the wall. We may see a ton of blood loss then, or if we go into a hemorrhage, we might see some blood loss then, and there may be hypovolemic shock as an issue. But usually, mom's body is pretty much prepared for this experience. It can handle it. The hematocrit levels drop pretty ridiculously for the first few days, right? So that as far as the thickness of the blood, like the viscosity of the blood, it's going to be thinner. And during the first 4 to 7 days after birth, we may see those white counts go up really high. Now, that's not an infection. So they may have 20,000, 25,000, even 30,000 for a white blood cell count after delivery. That's called postpartum leukocytosis. And it's just how the body works to heal and prevent infection. It just kicks itself into overdrive to make sure that nothing's going to get past it. We do see coagulation factors and fibrinogen levels rise during pregnancy, and those do stay elevated for the first part of that postpartum period, which means that client is at an increased risk for blood clots because of their hypercoagulability. Especially if they've had a C-section, we're worried about thrombus formation and potential thromboembolism. So we're checking circulatory factors. We're checking to make sure that mom doesn't have any red hot places in her hips or legs. We would check blood pressure pretty frequently. We may see a slight decrease in baseline, which could say that mom is bleeding, or a slight increase, which would be gestational hypertension or preeclampsia. We also may see orthostatic hypotension, especially the first 2 days after or so when we're changing positions. Our body is adjusting. So having mom dangle on the side of the bed is probably a great thing to do. Everything goes back to the state that it was before pregnancy by about 6 to 8 weeks. So there's a lot of different things that could happen, but most of the time we see everything go back to normal. What else I want you to know? Just make sure that mom's drinking lots of water, getting up and moving to keep from getting a clot. And then if there's pain or anxiety, distraction, imagery, relaxation, and give those meds as scheduled. As far as her GI system, you're going to see the potential for constipation. And obviously, we talked about those hemorrhoids, right? Ooh, no fun. So we'd want to make sure that the client has a good appetite and that they're eating well. We'll check for bowel sounds. We want to make sure they've got normal bowel function. It may take a while for them to have a baby because of that intestinal muscle tone being decreased during labor. So 2 to 3 days or so, they should have their first bowel movement. We should be checking to make sure that that's comfortable for them, that they're not super uncomfortable because of, episiotomy, lacerations, or hemorrhoids, and then documenting any hemorrhoids or varicosities that we see. High intake of fiber, increased fluids, early ambulation, stool softeners. We know that that is the ticket for constipation. If your client has a 3rd or 4th degree laceration, so something that's dipping into that rectal space, they cannot have an enema or suppository. And if they've had a C-section, we want them to pass that gas, right? So rocking in a chair and not eating gas-forming foods would be really encouraged for them. Just a review of a couple other systems that are going to change after having a baby. The urinary system and obviously associated with the bladder is going to change. We may have some urinary retention or distension, so it's important to be encouraging them to pee frequently. We're also going to see that postpartum diuresis, that increased urinary output after birth as they get rid of all that extra fluid. We got to make sure that the client is able to go to the bathroom, right? Because swelling could potentially block or obstruct the flow of urine. We also want to make sure that they're not peeing more than 3,000 milliliters per day after the first 3 days. So again, they can put out a ton of fluid initially, but after 3 days postpartum, they shouldn't be putting out so much fluid. Evidence of a distended bladder may be like excessive bleeding or tenderness in the belly, or maybe there's a bulge that you can actually palpate, which is the bladder, or that fundus is displaced, it's moving up or moving to the side, right? If the client is peeing just a little bit every time and very, very frequently, we're a little bit concerned about retention, maybe due to edema. So that's something to definitely document. These eyes and O's need to be properly documented. Just encourage your client to empty their bladder frequently. Make sure you're measuring and documenting their I's and O's. Make sure that they're drinking lots of fluids. And if needed, we can catheterize the client to help empty that bladder. The musculoskeletal system will also undergo some different changes. Remember, those joints loosened with that relaxin hormone. Those joints will return to the pre-pregnancy state after delivery, and they'll be completely restabilized. However, if your feet got bigger during pregnancy, you may see that kind of sticks around. So sometimes your feet grow and they stay that big. Muscle tone does get better throughout the body. Of course, we talked about the vagina is never going to have a total 100% muscle tone uh, recovery. But other than that, things should go back to normal in the abdomen and then the lower belly, etc. Now, if it doesn't, if there's a separation of the rectus muscle, that's called a diastasis recti, and it's where the muscles in the abdomen kind of separated during pregnancy because of the stretching of the abdomen. And so we hope that those go away within 6 weeks and they kind of grow back together. But if not, we may have to have surgery. When getting your clients up, make sure that you're following all proper fall precautions, that you're encouraging them to do simple exercises that aren't going to take a ton of energy, but can really help to maintain their tone. Make sure that they're using good body mechanics and proper posture. They shouldn't be lifting anything heavier than a gallon of milk or baby. And baby in car seat is what we always say. Get them up and moving, teach them about Kegels. All of those things will help with the musculoskeletal system. And then the last body system that we're going to talk about, as far as like physical body system, is their immune system. So if they were non immune to rubella or they had a negative or low titer, they obviously need to go ahead and get that vaccination. So that MMR vaccine can be given in the postpartum period. That way, babies don't have issues in the future if the mom gets rubella. And so, if she receives the rubella vaccine, it's really important that she doesn't get pregnant for the next 4 weeks because it could be dangerous to that fetus. And then, all Rh negative clients who have an Rh positive baby should go ahead and get that RhoGAM within 3 days of that baby being born before they leave the hospital. That patient should sit down. We should check their vital signs for at least 20 minutes after administration, make sure that they're not having an allergic reaction. And then varicella, that's chickenpox, right? So if the client didn't have immunity, we should give that varicella vaccine before they leave. And again, they shouldn't get pregnant for a month after getting that vaccine, and they'll need a second dose of that one about a month or two later. And then we always recommend Tdap for moms when they leave. That's because it helps to prevent giving pertussis or whooping cough to the baby. So they can go ahead and get that Tdap vaccine, and it shouldn't cause them to have any kind of issues or limitations. They can still breastfeed, they can do all of those things. Okay. As far as assessment and intervention for mom, we're assessing her ability to eliminate, her hygiene, that she's eating, that she's bonding with baby, that she feels good about herself and her capabilities, right? We may see some psychosocial changes. Clients can experience a bunch of different emotions because their hormones are very up and down. You need to be monitoring for signs and symptoms of postpartum blues or postpartum depression during that postpartum period. And if the client does have some symptoms, allow them to verbalize their feelings, do some frequent check ins, make sure that they're bonding with baby really well. And some signs of postpartum depression may be like a decreased appetite or difficulty sleeping or not really interacting or communicating well. Ways that we can help is by putting baby skin to skin with mama, really encouraging interactions and rooming in and being very supportive and making sure that mom has all the help that she needs and potentially even referring her out to counseling if there's obviously an issue. It's important that mom gets enough sleep, that she gets, that she's also moving her body. We don't want to see her get herself in a pickle with not enough sleep or not moving her body and developing like a blood clot or loss of muscle tone, right? I think that's pretty good. We talked about science go psychosocial assessment, infant abduction. So this is super weird, but people do steal babies from hospitals, which is insane. But it's important that we need to teach parents how to recognize that everybody has an ID badge on and how they know that they work at the hospital. They should only be the ones, parents and the staff should only be the ones transporting infants, never like a transportation person. Infants should never, ever, ever be left alone. And we never take back more than one baby at a time, always one baby to one mom. And we're matching the bands, the bracelets from baby and mom at the time of returning them to mom and taking them away. Okay. It looks like the book is going to go into healthy newborn. There's just a couple other things I wanted to talk to you about with postpartum. The first is nutrition. Non-lactating clients should be eating about 1,800 to 2,200 calories a day after they've delivered their baby. And if you're breastfeeding, it should be an additional 450 to 500 calories per day. If the client has a low hemoglobin and hematocrit, we want them to continue taking iron supplements and to take their prenatal vitamins for at least 6 weeks after birth. Okay. Hey, let's talk about baby. So, assessment of the healthy newborn. What do we see with our healthy newborn? So, this is jumping over chapter 13 and chapter 14 to chapter 15 in your ATI book. So the baby may be all different kinds of sizes, right? Anywhere from 5.5 to 8.8 pounds or 2,500 to 4,000 grams. Um, Baby might be 18 to 22 inches long or 45 to 55 centimeters in length. Head circumference is typically 32 to 36.8 centimeters, and chest circumference is typically 30 to 33. With these measurements, we can plot the baby to determine if it's appropriate for gestational age, small for gestational age, large for gestational age, or it has a low birth weight. Remember, to have a low birth weight, you have to be less than 2,500 grams, and things like smoking put you at risk for that. Some babies do experience intrauterine growth restriction. Early term would be occurring between 37 and 38 weeks, and then full term would be 39 to 40 weeks. What we see with intrauterine growth restriction is that the baby is not growing bigger despite it growing, aging, right, being in there longer. As far as their actual body, right? So like their body, we should see and document their skin color. They may have acrocyanosis, that's blueness of the hands or the feet. That is normal. Just no blueness of the face or around the lips. That would be central cyanosis or circumoral cyanosis. That would be very concerning. We're also going to be assessing the baby's breast tissue, their foot creases, their birthmarks, if their skin is peeling, if they're hairy or not, if they've got two painted nares, right, and can breathe through their nose. We're going to be checking their heart rate and auscultating at the PMI, right, for that nice heart rate and listening for murmurs, which are pretty common, unfortunately, in babies. We're going to auscultate for crackles, wheezes, and make sure the baby is breathing equally. Does it have a potential like pneumothorax? We want the belly to be nice and round. The umbilical cord should have one vein and two arteries. We should be verifying that. Muscle tone and reflex reaction should be normal. Remember, we can do that like the startle reflex, the Moro reflex, where we drop the baby from a very, very slight height to see what it does. It should do that shaking of the hand startle reaction. We should be observing the fontanelles and sutures to make sure that they look good, looking for signs of swelling in the head, and then any type of gross structural malformation like a cleft palate or a spina bifida, anything like that. To do our assessment, it's important to have a bulb syringe for suctioning any excess mucus that they have, a stethoscope for auscultating heart rate, breast sounds, bowel sounds, and a thermometer to check under the armpit for temperature. Now, we do not want to check a rectal on a baby. There's also itty bitty tiny blood pressure cuffs that we'll do. We'll do a blood pressure on our baby, and we'll also do one with their cardiac test to verify that there's no discrepancy. We'll need to get the baby's weight on a scale and measure their length and circumferences with a tape measure. Um, so all of that is necessary in order to do our assessment. Remember, with our vital signs, will be a little bit different. Respiratory rate will really vary. It should be anywhere between 30 and 60 breaths per minute with apnea periods. Remember, apnea or the cessation of breathing is normal in the newborn, which is crazy. That could last up to 20 seconds of not breathing, and it's totally normal. If it's longer than 20 seconds, we have concerns and we need to tell the doctor. Crackles and wheezing could tell us that we've got fluid in the lungs or potentially an infection. And if the baby is grunting or flaring its nostrils, that is not normal. That tells us we're in respiratory distress. The baby's heart rate should range between 110 and 160. And if it is like really angry or crying, it may be up. If it's sleeping, it might be down. We need to be auscultating an apical pulse and count that for a full minute with that pediatric head of our stethoscope. Heart murmurs, again, are common, so we should document those and report those if we hear them. Blood pressure should be between 60 to 80 over 40 to 50. And that's part of our congenital heart screening as well. Our temperature should be anywhere from 97.7 to 99.5, so 36.5 degrees Celsius to 37.5 degrees Celsius. Of course, our newborns are not good at regulating their own temperature, so hypo or hyperthermia is certainly possible. If the baby gets really cold, they could go into a cold stress, and that could put them into a respiratory situation where they're breathing and needing more oxygen and not able to sustain their metabolic processes. So that's not good. It's important that we get these vital signs, immediately after birth, but then that we're frequently doing those per those recovery guidelines, and then that we're doing a head to toe and a set of vitals with every shift change or every 8 hours. Okay, baby should be lying, curled up, arms and legs should be flexed. They should be resistant to you extending their legs. Again, their skin color is typically deep red or purple. Acrocyanus is normal. If they're yellow, we're concerned about increased levels of bilirubin and potential jaundice. That yellowing would also move into their eyeballs. Their skin turgor should be quick. So when you tent up their skin, it should spring right back down when you pinch it. They should be dry, soft, and smooth. If they have cracks, that's okay. And peeling is also okay. They're covered in that vernix caseosa or that thick cheese when they're born. If there's not a reason why we need to bathe the baby, we can actually leave that on and it helps to protect their skin and also can put them at decreased incidence of for eczema and psoriasis later in life. The baby may be covered in a little bit of hair. It's called lanugo. It's really soft. It's usually on their ears, their forehead, and over their shoulders. The baby may also have milia, which are little pearly white spots on their nose, chin, and forehead. You should not squeeze these, and parents definitely should not squeeze these. We just leave them alone. They go away on their own, and they're not like acne, even though sometimes we call them like baby acne or whatever. Babies also may have some normal deviations like Mongolian spots. That's a blue, gray, brown, or black spot on the baby's back or buttocks. This is not abuse. So a lot of people are like really nervous about this. It is not abuse. It's not a bruise. And we see this a lot with darker complected babies. It is genetic. Make sure parents know that they have these and where they're located. Another thing we may see are stork bites. Typically between the eyebrows is where we see that, but it may also be found on the back of the neck, the nose, the upper eyelids. It's called telangiectatic nevi. I really butchered that, but just bear with me. And these sometimes fade by year two, but sometimes they don't. Sometimes it's a birthmark for the rest of their life. Another one we see is nevus flammeus, a port wine stain. This is capillary angioma, so it's got vessels in it, right? So it's going to be purple, it's going to be red. The size, the shape kind of just depends on the distribution there. And oftentimes these are on the face. When you push on them, they don't blanch, right? And they don't won't ever go away. Babies will just have that port wine stain forever as they grow up. And the last thing that we can kind of see as a normal skin deviation is erythema toxicum. That's a pink rash that covers the baby's body. And it can be there for the first 3 weeks or so. Do not do anything about it. It does go away on its own. It sounds really scary, erythema toxicum, but it's basically just a baby rash, like a totally normal baby rash. Okay, so looking at the baby's head, the head should be 2 to 3 centimeters larger than the chest circumference. And if it's bigger than that, like 4 centimeters or bigger, we're worried about them having fluid inside of the brain. So, like hydrocephaly, right? That would be concerning. And if it's smaller than that, we're worried about microcephaly, which could be associated with several different types of infections or disorders or potentially even syndromes. We should be able to palpate and feel that anterior fontanelle. It should be about 5 centimeters on average, and it's diamond shaped in the front portion of their skull. The posterior fontanelle is a lot smaller and it's more triangle shaped. All the fontanelles should be soft and flat, but when they cry, they cough, or they throw up, it may bulge. That's okay. Bulging fontanelles, when they're active, is totally normal, but at rest could tell us that we have increased intracranial pressure, an infection, or potentially hemorrhage, which would be very concerning. And if those fontanelles are dipping in or depressed, that baby may be dehydrated. Their sutures should be palpable, separated, and could be overlapping, which is totally normal. That's called molding of the head bones. And then we may also see a couple different deviations, like caput succedaneum, that's swelling of those soft tissues. It's an expected finding. So this is totally normal. This is like that alien head that babies get. It goes away on its own within 3 to 4 days. You don't have to do anything about it. Caput succedaneum. It's just the soft tissues that are swollen. Something a little bit different than a caput succedaneum is cephalohematoma. That's where blood actually gets in between the periosteum and the skull bone that it covers. It doesn't cross the suture line, but this is caused by trauma, right? So difficult or prolonged labor, forceps delivery, vacuum assisted delivery. We see these within 1 to 2 days after the baby is born, and they go away by week 8. Talking about the baby's face, like their eyeballs, we want them to be symmetrical. We want each eye to be at appropriate spacing. If there is an abnormality in the spacing, we may be concerned about things like Down syndrome or fetal alcohol syndrome. The lacrimal glands on the baby are immature, so we may not see any tearing, and there may be bleeding into the eyes. That's usually from pressure during birth. I would document it, but it is a normal, abnormal finding. The pupillary and red reflex should be present, and there may be some jerking to the eyeballs. That's totally fine. So are cross eyes or the inability to focus, right? These little babies' eyeballs are not ready for the big world. Looking at the baby's ears, they should be there should be, if you draw a line from the inner to the outer canthus of the baby's eyeball, that should be even with the top notch of their ear. If it is low set, we may be concerned about like Down syndrome, a kidney disorder, or again, fetal alcohol syndrome. The cartilage of their ear should be firm and well formed. If it's really smooshy, they may be premature, right? The baby should respond to voices and other sounds. You would want to document if you saw any ear tags. And of course, we're going to do a hearing test on baby. The nose of baby should be midline, flat, and broad. There won't really be a bridge to their nose. They may have some mucus in there. Um, they are obligate nose breathers. That means that they have to breathe through their nose and they can't open up their mouth to take a breath until about 3 weeks. So if there's any blockage in their nose, that could be really dangerous for them. They could have start to flare their nostrils. They may become cyanotic, and they could eventually even asphyxiate. So it's super important to make sure that they have clear nasal passages. And the babies will sneeze to help clear them out, but you can also bulb suction baby. Baby's mouth should have a closed palate. They should be able to suck with symmetrical lip movements. There should be a little bit of saliva, but not too much. If you have too much, you may be concerned about a tracheoesophageal fistula. The baby may have Epstein's pearls. They're little small white cysts on their gums, totally normal, and they go away after a few weeks. Their tongue should move freely and be symmetrical and not protrude. If their tongue is attached to the bottom of their mouth, it could be too firmly attached. They could have a tongue tie. We may choose to cut that. Or if the baby has a protruding tongue, that could be an indication of Down syndrome. They should have a soft and hard palate intact. And if they have gray or white patches on their tongue, that could tell us that they have thrush. Remember, Candida albicans. The baby's neck should be short and thick with skin folds and no webbing. They should be able to move their neck side to side, up and down. If they don't have head control, may be premature, or they may also have Down syndrome. Their little chest is barrel shaped and they breathe with their diaphragm. Their clavicles or their collarbones should be intact. And when you palpate over them, you shouldn't hear or feel any crepitus. They should have normal work of breathing without any retractions. Retractions would be indicative of respiratory distress. Their nipples should be prominent, well formed, and symmetrical with little breast nodules between 3 and 10 millimeters in diameter. With their umbilical cord should not be smelly. It should have no intestinal structures located in it. Their little belly should be round and dope-shaped and non-distended. They should have bowel sounds present almost immediately after birth. Their anus should be present and patent, not covered by a membrane, and they should have a baby poop or a meconium poop between 24 and 48 hours after delivery. The genitalia of the male newborn should include rugae on the scrotum. So their scrotum should have those little ridges on them. Their testes should be down inside of the scrotum, and their urinary meatus should be at the penile tip. Sometimes that opening that they pee through may be on the top or the bottom. That would be concerning and need to be reported to the doctor for a revision. Female genitalia may be a little bit different. We should see labia majora and minora. Usually the labia majora cover the inside labia minora and the clitoris, but everything is pretty swollen right after delivery. A little bit of blood-tinged discharge is totally normal in a female newborn because of mama's hormones, and there should be a hymenal tag present on this baby. The baby should have an episode of urination within 24 hours, and you may see what's called brick dust. That's uric acid crystals that are like rust colored for the first couple days. That's totally normal. With their extremities, you want to make sure that they've got full range, symmetrical, spontaneous movements, that they flex their extremities and that they don't lay all flaccid. You want to make sure that their legs aren't bowed and their feet aren't flat. That would be concerning about some kind of musculoskeletal abnormality. When abducting the hips, there should be no hip clicks heard, and the gluteal fold should be symmetrical. Their soles of their feet should be well lined. They should have lots of wrinkles in their feet, over 2/3 of their feet at full term. And their nail bed should be pink with no extra toesies. Their spine should be straight, flat, midline, and easily flexed. and the baby should be able to suck well. So the baby is going to cry. Remember, crying is the only way the baby tells you that they need something. They may be hungry, in pain, or just want to be held. Newborns usually spend 16 to 20 hours per day sleeping, and the rest of that time is spent crying, eating, or just being kind of still. Most babies don't sleep for more than 5 hours at a time, and that's pretty normal. If the baby gets a circumcision, it's important that we talk to mom and dad about how to take care of the baby. You don't want to get the circumcision. You don't want it to be super moist. You want to make sure that you put some Vaseline inside of the diaper so that it doesn't adhere. You want to assess for bleeding. And if there is a little bit of yellow exudate or crusty yellowness, we leave that alone because that's helping it to heal. We don't clean that off. As far as the umbilical stump, we don't want to get that wet, and we no longer recommend alcohol or peroxide on that. We just let it kind of dry up on its own. It's important that we encourage mom and dad, or mom and mom, or whoever we've got at home, and the baby to bond well. So we want to make sure that we're doing skin to skin and early contact and encouraging them to interact with baby and do the cares for the baby. Babies require a lot of nutrition. They require approximately 120 calories per kilogram of their body weight every day. So, breast milk and prepared formulas will help meet that need. And they need about 140 to 160 milliliters per kilogram of fluids per day. And how frequent we're feeding is going to depend on what type of feeding we're doing and baby's demand. So if baby becomes, is crying and will not stop, here's some things we can do. We can swaddle. We can do some rhythmic, monotonous noise. We can do or monotonous noise. We can do some skin to skin contact. We can look at baby in the face. We can stimulate baby. So trying to get that baby to quiet down. Hey, just a couple other things I want to tell you about that we didn't touch on quite yet are the reflexes. You need to know these reflexes. So we assess neonatal reflexes like sucking and rooting. So stroking the baby's cheek, they should be turning to grab that finger and start to suck. This is a expected finding. The baby should have that reflex for about 3 to 4 months. The Palmar grasp, that's that super cute one where you put your finger in baby's hand and it grabs it, right? That is a reflex. As sad as that is, it is a reflex, but they should have that Palmar grasp reflex, and that'll be there for about 3 to 4 months as well. We also will see a plantar grasp reflex. That's where we put the finger at the base of their toes and their toes curl in. They'll have that till about 8 months. The opposite of that is the Babinski reflex. So by stroking the outer side of the foot up towards the toes, they should flare their toes. That's a positive Babinski. If they don't flare their toes, we're concerned about their neurological status. So they should have that for about a year. We also see that Moro reflex, or um, that reflex is where we allow the head and the trunk of the newborn to kind of fall back real gentle, and the baby kind of extends their hands and their arms. Um, so we expect to see that until about 18 weeks, and it should be gone by 6 months. The baby will also have tonic neck reflex, or the fencing position reflex. So when the baby is laying flat on its back and you turn its head to one side, its arm and leg on that side will extend, and the arm and leg on the opposing side will flex. It's kind of cool. When you hold baby up, it'll do a stepping motion, kind of looks like it's walking, right? We see this for about the first 4 weeks. That is a normal reflex. And regarding baby's typical baseline capabilities, babies are only able to see about a foot away from their face, so 8 to 12 inches away from their face. They're very sensitive to light, so dim lighting is better for them. And while their pupils are reflective or reactive, it's important to assess that minimally, just as we need to. Term newborns can see objects that are 2.5 feet away, and by 2 to 3 months, they really can tell colors apart. As far as hearing, it's really pretty much the same as an adult, as long as they don't have a bunch of fluid stuck in there. Touch, they'll respond to touch. They obviously can feel pain. Newborns can also taste, and they really like sweet things instead of salty, sour, or bitter things. They have a really good sense of smell that helps them to smell their mama and their mama's breast milk. And the baby pretty used to that happy inside, warm, gushy, mushy environment. So baby can become overloaded by stimulus in the environment as well. So it's important that we just encourage mom to bond with baby as much as possible and holding baby skin to skin. Now, if baby does have pain, we use one of two different scales most commonly, but there's a couple other ones that we may also use. So we use the CRIES scale and the NIPS scale, the neonatal infant pain scale. And those are going to see what kind of things baby is doing. Are they crying? Are they moving their limbs? Are they consolable? Those kinds of things. Okay, I think that that's it for normal baby. We'll talk about nursing care of baby a little bit more in depth when we talk about complications. I think the rest of it's pretty good. Make sure that you're reviewing chapter 16, since I'm not going to be hitting it super deep in detail, including the medications we give baby and information about newborn nutrition, bottle feeding versus breastfeeding.